talk about incorporating a palliative approach into your family practice. I'm coming from Hamilton, Ontario. It's about 45 minutes west of Toronto. It's an urban city with about 600,000 people. And I work in a large academic family health team. I've got about 1,200 patients in my practice. And when it comes to providing palliative care, I do this mostly in people's homes, but I also do it in hospice, I do it in hospital. And then where I've probably learned the most about palliative care is, of course, within my own practice, which is why many of you are here today. And my greatest hope for today is that I've assembled some learnings, some tips, and sometimes some frank epiphanies that I hope you will find useful today. I have nothing to disclose. This presentation really reflects my own experiences and insights, but I do have a couple of stipended roles as a medical director of a hospice, as well as the clinical co-lead for palliative care for Ontario Health West. All right, so I took over my family practice in 2017, and this was me on day one. And it had absolutely nothing to do with family medicine. I have major imposter syndrome. But it did have to do with palliative care. I felt like I was finally an expert in something. And it's no wonder, considering how this is trained in our medical education system. We're often in the hospital. The patient is there yet again with multiple complications and failing multiple treatments. And no one's looking at the big picture. Enter palliative care. Or pain and symptom management, if that's what your institution prefers to call it, because the P word is seen as a bad word. And this team has a whole 90 minutes sometimes with the patient to discuss their illness, their symptoms, and many other important topics that no one's really broached before. You tell them that they have weeks, not months or even years to live, and somehow they thank you, and you walk out of that room feeling like a hero. And I always joke that many of us that go into palliative care are the ones that need our egos stroked the most. Well, this hero persona for me dissolved very quickly, and that was when I first diagnosed my family medicine practice patient with pancreatic cancer. It wasn't so much about the diagnosis. I think these skills are quite fine-tuned in family medicine. It wasn't even about breaking the bad news. Greg put me through the ringer. He came with a bunch of trauma, he came with addiction, he came with existential distress, he came with wanting to try a number of different experimental therapies as well. He was a crash course for me in what I didn't know, and that was the massive gap between diagnosis, which I got in family medicine, and then end-of-life care, which in retrospect I realized is what my palliative care training was about. And so these are the objectives for today. There are many tools out there for delivering a palliative approach: algorithms, calculators, conversion guides, toolkits. They're good, they serve a purpose, especially for those who are starting to learn how to incorporate these skills. But what I've come to see in family medicine over time is that a lot of these tools don't incorporate naturally into the day-to-day work that we do. And that's what I'm trying to do today. I want to explore through key principles and concepts what's helped me do this work better and in a more natural way within my own family practice. My approach to this work comes with 3 assumptions. The first is about a palliative approach. This is different from palliative care in that palliative care is a specialized medical service. It is upstream, it is performed by non-specialists, and it encompasses 3 domains: whole person care, quality of life focus, that's just good care, and then the domain that makes it unique, and that's mortality acknowledgement. And then we recognize that death, dying, loss, grief, and bereavement are universal experiences that can impact us at any time. We all have a role to play in this type of care. It's commonly quoted that only 15% of people really need a specialist palliative care team involved at some point in their final year of life. Family medicine, of course, is ideally situated due to its comprehensiveness and the continuity of care that it offers. The third assumption relates to the quintuple aim. Yes, there are 5 of them now. We have lots of evidence to support how an upstream palliative approach benefits all of these aims: population health, patient experience, cost, health equity. The one I'm honing in on today, though, is the provider experience, because this work is inherently rewarding, and often it brings us back to why we went into medicine in the first place. I have a mentor who regularly acknowledges that yes, death can be hard, but it can also be quite beautiful. Of course, there are barriers, system barriers. I am not going to go into detail to this room about why it is so challenging to work in family medicine today. But I will highlight that we do have a problem with continuity. I didn't recognize right away anyways how hard it was going to be for me to hold on to some of my patients once I referred them on to a specialist, especially in the oncology world. So with family docs being overwhelmed and systems designed as antidotes to continuity, it's no wonder that more than half of Canadians still die in hospital. Furthermore, about 1/5 of their total health care costs in their lifetime are spent in that last year of life. And then there are patient barriers. So we keep hearing about this death-denying society, and it's a hard thing for me to wrap my head around as a palliative care provider, because when I speak to patients about their illness, I'm often thanked for delivering real information, and often asked, well, why did nobody tell me? Regardless, we have an aging population and more people are dying. Their predictable decline from illness to death is no longer as common. Most people live for months or even years in a state of vulnerable frailty. In fact, only about 10% of people die suddenly. And then we have clinician barriers. Our comprehensiveness as a field is declining. Through the CFPC longitudinal survey in 2022, 35% of family physicians reported that palliative care was not part of their family medicine practice. And the highest attributable factor for this was a lack of interest in the domain of care. This was even more so than feeling competent or confident in the type of care. Other barriers, of course, were lack of training and mentorship. This, of course, is variable across the board, both in medical school and residency, time, and models of compensation. Something else that will influence your ability to do this work are the practice models in your own community, and you really need to reflect on this. Because in our neck of the woods, there have been some individuals and there have been some groups who have been expected to take over care once a patient is deserving of a palliative approach or benefiting from a palliative approach. And negative consequences have resulted, such as those taking over the care being burnt out, and then family medicine having their competency and capabilities of providing this care declining over time. And of course, that's good news. That's why we're here today. So I think that if you can buy into those 3 assumptions that I went over earlier, and you can tailor your practice, the way that you do it, to move some of the things that you're already doing, and maybe some new things upstream, the benefits are very much going to outweigh the barriers. And it starts with identification. We've been stuck on early identification for years, and we have to ask ourselves why. I think we all know how to identify a patient who is going to die from a progressive illness. I think the big barrier is then, so what do we do with them, especially upstream? And I think this has a lot to do with our medical training. For many of our careers exist in hospital settings, so knowing how people live and die outside of the hospital walls is actually a big mystery to many of us. So how do we counsel patients around what the alternatives look like? So the terms early, earlier, earliest, they're all relative. And we often focus on the last year of life, and I would say that that's just an arbitrary measure. We hear about the surprise question. Would I be surprised if this patient in front of me died within the next year? And then we are supposed to implement a palliative approach if our answer to that question is yes. The earliest time to implement a palliative approach, of course, is before somebody is sick at all. It might happen naturally with the patients we know best and are forthcoming about what is important to them. Advanced care planning campaigns tend to focus on this type of care, these types of conversations. But moving more downstream in our natural practice settings, we might identify patients a little bit more downstream. So cancer diagnosis is obvious. Sometimes it's when people are admitted to long-term care, when they start second or third line therapies, when they're in hospital not once, but twice. And then there's other natural opportunities like coming to see you more, or a change in function or frailty, or a family member that raises a concern about their loved one who is also part of your practice. And then all too common are the latest, not early at all. And that's when the wheels fall off. The patient is referred, and they're caught up in the vortex of the healthcare system of multiple specialists, multiple treatments, multiple strategies. We get notes from all of these people outlining all of the various types of chemotherapy and radiation fractionations that they've tried, all of the medications that they've started and come off of, but no real useful information about how they're doing. Their ejection fraction is 10%. We're going to continue current treatment. We'll follow up in 6 months. And then suddenly, the patient can't make it into the hospital anymore. And depending on the community that you work in and the models that it employs, family medicine can be left to pick up the pieces. And then there are the missed patients entirely that's a bit beyond the scope of today's talk. These are the ones that slowly stop visiting you. Often it's because they face isolation and social and structural barriers. And then there are our own unconscious biases. If you close your eyes and you take a second to imagine a patient with dementia, who comes into your brain? For me, it's still the old, frail white woman. Over the last few years, I've been identifying these windows of opportunity for starting these conversations and moving this care upstream. So again, going back to the earliest, we all have patients, they tend to be older, who still want to have their annual physical exams, no matter what we tell them. And so the approach I use is, hey, I've started this new thing, I'm doing it with everybody, Bob. It's called advanced care planning. It's a great time to fit that in. We also have elderly patients typically whose social networks are getting smaller. Their friends and their families are dying. And I can then broach the topic, when people find themselves in that situation, I find they often reflect on their own mortality. Is that something that you've been doing? A hospital visit for themselves or for somebody else? A good question is, how can we make sure that you don't experience that again? Most people don't have good experiences in hospitals. A health scare? What's your biggest fear, thinking that this might be the diagnosis for you moving forward? Cancer remission, right? They get discharged from their oncologist and they're sent back for their annual breast exam. Taking a minute to clarify why we're doing this. Ruth, would you want to know if you had cancer again? And if you did, would you pursue those treatments again? And then discussing family history, a really benign way of approaching some of these conversations. Our beliefs and conceptualizations about death are affected by our past experience. So would you describe the death of your mom or your dad as a good death? And if so or not, why? Later ways of broaching these conversations often happen around a patient having a serious illness. And so what I have to do in these situations is, first I have to sell myself to patients. I have to let them know specifically what it is that I can do for them. It also provides reassurance. They're not alone. More on this later. But there are two bang-for-buck questions that I ask patients that are facing a serious illness. And the first one is, Bob, have you noticed a change in yourself? Most people can answer in the affirmative. The follow-up question to that is, what do you think is going on? And you might hear vague things like, I'm getting older, isn't this normal age? And you just continue to throw it back. What do you think? A second question is, we've talked a little bit about your CHF, and we know that it's going to progress over time, and knowing that that's going to be a part of your future, what are your biggest fears? Some people will stop and say, I don't know what you mean, what are my fears? And so we can list them, because we know common fears for people heading towards their final years of life. Things like symptoms. And if they're afraid of symptoms, I can talk about our big toolbox for managing them. If they're afraid of loss of control, I can remind them that you drive the bus moving forward. Everything we do is based on your values and your goals. People are afraid of what's going to happen to their loved ones once they're gone, and also that they're going to be a burden before they're gone. You can facilitate open communication with those families. People have concerns or regrets about their impact on others or even in their own life. You can provide supportive counseling. And then there's the unknown. Lots of people are afraid of the unknown, and we can always just approach this with a sense of curiosity. We don't have to know the answers for everything. And then we wish, we worry, and we wonder. So I can say, Esther, I wish you weren't noticing these changes in yourself. I know you're not the same woman that you used to be. And like you, I do worry that this is related to your heart, and that it is starting to get worse, and this is going to have implications for you in your future. And I wonder if you'd be willing to come back and have some more discussion with me about that. So wish, worry, wonder. Many of you have probably heard about it before, but these questions lead up to me inviting the patient back. That's the important piece. You will have time to reflect on how you can make that conversation and take it forward. So it's often at this stage I get questions about the people that just won't go there. And this is an invitation from me to you to walk two roads, as my mentor, Sammy Winemaker, would say with the patient. You can still hope for a miracle with a patient, but you can also follow that up with one thing we do know, however, is that if we hope for this best, and we plan for alternative outcomes, people live longer and they live better. We have evidence to support that. So that's language I use with patients. We can also remind them that when they imagine what is to come, it's often way scarier than the reality. The things we imagine in our brains can be pretty horrific. People are often reassured when they hear that. And then if the patient wants to remain unknowing for the time being, I tell them that that's okay, but somebody has to be in the know. That is the only way that we can make sure that your values and your wishes are met throughout this journey, especially if you're wanting to die at home. And some reassurance for all of you, it is exceedingly rare for people to take the unknowing stance all the way to the end. You might hit this brick wall up front, but with time and building some trust, it's often not the way that it ends. So I said that I have to sell myself. I make it very clear to people that I want to help them live as well as they can for as long as they want to. I'm their quarterback moving forward. There's going to be a lot of moving parts to their care, but I'm the one who's there to help organize. And then I divide my roles into 3 buckets. The first one is illness understanding. What do you know about your disease? The second is symptom management. That can be physical symptoms, psychological symptoms, spiritual symptoms. And then the third one is about planning for the future. So again, that is the hoping for the best and preparing for the rest. And these buckets are just really good ways I've found them for organizing my thoughts, but also for the patient to organize their thoughts and maybe some of the questions that they're coming to the table with. A brief warning about assumptions. Some of the biggest mistakes I have made come from assuming something that I shouldn't have. So, assuming what people know. When is the last time you asked a patient what COPD was? Or what CHF was, or where the cancer is in their body? I'm always shocked at how little people know about their actual disease. So going back to basics and not making assumptions about what they know is really important, especially if you're taking over a practice. How they know. So this is asking patients, how do you like to receive information? Are you a give it to me straight, Dr. Gallagher, don't sugarcoat it, I want all the details? Or do you find too much information at once a little bit anxiety provoking and you're more of a day by day? And you don't just ask the patient that question, you also ask the family, because not everybody's on the same page, and you don't want to cause distress in the patient, and certainly not the caregiver, who is really your care team at home. They're your nurse, they're your PSW. They are also, of course, the family member. And so we can tailor this information based on the different levels that people want to know, especially if we're given permission from the patient to talk maybe more openly with their family members than with themselves. And then the last piece is how they're doing, right? I've made assumptions about how people are doing. Looks can be very deceiving. And unfortunately, in this era of virtual care, when sometimes we're not, but also the specialists that are treating our patients are not seeing our patients, not laying eyes on their patients, that can actually be more dangerous. Laying eyes is really important. A brief plug on disease societies. We've probably all heard of the Alzheimer's Society, ALS Society, Parkinson's Canada, the Canadian Lung Association. These are great tools and hopefully a good reminder for you guys to tell your patients and their caregivers to plug into this information. But there's also great information for you as providers around these conditions. But no matter what the illness, patients are at risk of getting caught up in the chaos of the system with their multiple appointments, providers, and treatments. And many say that they've lost their personhood. No one is zooming out to take a look at the big picture, which is very much something that we can do, that we can help with. Many patients want to know where they're at in their illness. Prognosis is a big part of this. Specialists, when they're asked, usually start with population data and they bookend it. So with X cancer, people generally survive 3 to 6 months. Well, what happens at 3 months? Everybody panics. And then what happens at 6 months? People start questioning everything that they've been told. So you can encourage patients to ask for this information from their specialists if they want to know. But you'll have to give some caveats. And then you can tailor that information from there. You can zoom out while considering the whole person, not just the physical processes of how and when they'll die, but also their ability to live the way that they want to, if they're going to be working, continue hobbies, travel, anything that they have left to do. You'll likely recognize these trajectories. I have a mentor who has always joked that if she was to get any tattoo, it would be these 4 diagrams on her arm because she refers to them so much when she's talking to her patients about their illnesses. So other than the top left, which is sudden death, that's the 10% again, most people just experience more complications of their illness as they progress towards end of life. So on the top right there, you have terminal illness. That's going pretty steady until there's a sudden drop-off. Those are things like cancer. If that steady is a really long and prolonged state, when the drop-off happens, people can be generally very surprised. We see this actually in pediatric palliative care because they tend to have longer steady states and good trajectories. And then the drop-off, everybody is wondering what's gone wrong. Whereas a visual shows that no, we were actually expecting this at some point. Bottom left is organ failure, so lots of exacerbations, and every time you're treated and the function comes back up, it doesn't return to that baseline again. It's hard to tell when that final plummet to death is going to be sometimes. And then frailty starts at a low baseline function in the first place, and it's a slow dwindling towards death. So these are general trends. This is the Palliative Performance Scale, or the PPS. This is a snapshot for people and their function. It is not a prognostic tool in and of itself, but the rate of change in PPS status can be. People want, value, and deserve prognostic information. So we have to be able to tell them this and not shy away so they can prioritize how they want to spend the rest of their time. And I give it to people in sort of a framework that I'm going to share with you now. It's very generic, but I think you'll get the gist. So we know that people with disease A live on average B number of months or years. But you also have comorbidity C, which may shorten this time. We are waiting to see if you have a response to treatment D, which could further impact your prognosis. Knowing that this information is important to you, I can promise to keep you regularly informed as I see things change. What I do know now, though, is that our biggest predictor for prognosis is how people change in their basic function over time. That means getting out of bed, doing your personal care, eating, staying awake, perhaps even getting out of the house. If we see people changing on a week-to-week basis, their prognosis might be in the manner of weeks to many weeks. If it's slower than that and they're changing on a month-to-month basis, then their prognosis might be in the manner of months to many months. And then sometimes people surprise us. They leave us faster than we thought, or they live longer than we thought. And the latter, younger people typically do this to us. But that's why it's important for us to plan ahead for various scenarios to ensure that you're living as well as you can for as long as you want to. In some ways, prognosis is out of our control. I can't take the cancer away, and nobody else can at this point. But in other ways, you do have control over your prognosis. More on that later. So, moving on to some symptom management, this is obviously not a comprehensive session for symptom management. So instead, I've decided to focus on some basic principles that you can take with you in managing your patients moving forward, but also there's lots of literature to read up around. Having resources is a good place to start. A palliative care pocketbook or pain and symptom management resource. There are tons out there. I haven't listed any specific ones because I don't think I'm allowed to advertise things that you have to buy today, but if you want to come up after and ask me for some tools, you're more than welcome to. Start with goals of care, no matter what. If you're going to treat a symptom, whether you look into the cause will probably depend on where that patient is in their trajectory of their illness. If they're in final days, you may not look for the cause of the symptom. You may just treat it. And what you treat it with may differ, because if a patient does not want to prolong their life anymore, theoretically, an antibiotic could prolong their life. Symptoms are often multifactorial, so don't just stop when you hit the primary cause. There's usually many. And we also have this concept called total pain or total symptom. And really, that's just the mind-body connection. If you are distressed up here, your physical symptoms are going to be way worse because of it. In this field, it's actually kind of fun. We can use side effects to our advantage. I've always said that if I die, not if I die, when I die, I just want to be on an IV of dexamethasone. I think it's the best drug ever. It helps with pain, it helps with inflammation, it gives people energy, and it gives you an appetite. So you can imagine why that would be helpful in this population. Opioids are not just for end of life. In our region, I have yet to see a respirologist start a small dose of an opioid on an advanced COPD patient that is struggling with regular dyspnea. And I have done this, and it has been truly life-changing for patients. Unfortunately, starting them late also contributes to some of the myths around opioids. Trade-offs are common. And I think we need to be overt about this with our patients. Often as they progress towards end of life, some of the treatments that we've used to manage, say, their diabetes or their blood pressure might actually harm them. In order to manage a symptom like breathlessness because they have fluid building up in their lungs, might help with the breathlessness by giving them some diuresis, but it might make their kidney function and cognition worse. Action plans are crucial. These are for the things that we hope don't happen, like a seizure, in somebody who has brain metastases, but also for things that we know will probably happen, like exacerbations in COPD and CHF. COPD, making sure that they know the signs and they have access to the antibiotics and the steroids to treat their symptoms and the illness, again, as long as it's within goals of care. Pill and appointment burden, right? Lots of pills typically in these populations. Some of them, as I said before, cause more harm than benefit. Some of them are meant to benefit over decades, which is no longer the scenario. And then we all have those 90-something-year-old patients who still religiously go to their cardiologist for their twice-a-year follow-up. And so checking in and seeing really what the purpose is for those visits, and if those things can be managed at the family doctor's office, which is often closer and easier to get to, that's permission that you can give to their patient that they didn't even know they were looking for. And then MAID, beyond the scope of the conversation today, of course, but it's important for us to recognize that this is a sign of a symptom. It is either current or perceived suffering. That's what an inquiry about MAID is. And so we need further understanding about that. I have tailored my approach to discussing MAID, and there's lots of debate out there about who should bring it up. Should it be the doctor? Should it be the patient? Should it be no one? Well, I'm going to tell you my approach, which may or may not jive with you, but before MAID, I used to spend a lot of time talking about the big toolbox that we had for patients and their symptoms. And then I would say, in the rare circumstance, and it is rare, that we couldn't get on top of your breathlessness, we have in our back pocket, in final days of life, something called palliative sedation. And then I would explain what that is. The only way I've altered my discussion about this since MAID is to say, and now we live in a country where people can actually use the services of a physician to end their life. That's called MAID, or medical assistance in dying. Sometimes people have heard of it and they have lots of questions and they take the discussion that way. Others just sort of take it in like everything else and it's left there. That's worked well for me. The last slide on symptoms is about screening. This is the Edmonton Symptom Assessment Scale, or the ESAS. Many of you probably know about this. It's got the most common symptoms that people that are receiving palliative care experience, and it's on a scale from 0 to 10, 0 being no symptom, 10 being the most. And we can give these to people over time to see the progression of the disease, but also the effect of the treatments that we're offering. What we do know, and we have lots of evidence to support this, is that if we ask general questions to patients like, how are you feeling? We will only get about a quarter or a third of the symptoms that they're actually experiencing. We also know the patient has to do this, because if we do the ESAS for a patient, we will tend to underreport, we will give them lower numbers. And if we ask a family member to do it, then they will overreport. It will be higher numbers, again, on average. On to the last bucket, planning for the future. So when we are having these important conversations, it's crucial to recognize the conversation we're in, so we know what the goals are that we're actually trying to achieve. So advanced care planning on the far left, these are those conversations that are supposed to happen early and continue over time about patients' values and wishes that would direct their care. It's also about identifying a power of attorney who could speak for them in case they couldn't, and also communicating those values to the power of attorney. Questions that have helped me have these types of conversations are, what gives you meaning in life? What are some essential abilities that you have right now that if you no longer had them, you wouldn't feel as though life was worth living? When your function declines and you can't look after yourself the same way, who will you have look after you? Who knows you well enough that if you couldn't speak for yourself, they could speak for you? Do you have any financial concerns down the road? Because you know what, dying is expensive, especially if you want it to happen in the home. Expensive to the individual and the family, I mean, it's very expensive in a hospital. Do you and your family have personal benefits that might be able to support things moving forward? And then, of course, asking about religious and cultural concerns, because they can have a significant impact on people's journey moving forward. For goals of care discussion, this is, what do you want to get out of the intervention that we're offering or that we're even taking away? And this is all related to quality of life. And I say people fall on a spectrum here. On one end of the spectrum, people say, Doc, I don't care what you have to do, you do it anything to help me live longer. Not many people fall over here, right? And then on this end of the spectrum, we have people who say, my quality of life is so poor, as defined by myself, that I don't want anything done to live longer. And what I make clear to patients is that comfort, which is what they're choosing over here, is non-negotiable. We aim for that no matter where you are on the spectrum. And then there are people in the middle who are doing okay. They're happy to stick around. Life's pretty good. It might not be perfect, but it's pretty good. And so when they run into the next complication of their illness, they would be open to treating it, say, with an antibiotic, for example, because they hope to stick around longer. And their baseline function is so good that they're wanting to preserve it. And then finally, there's decision making, right? This comes at the far right of this slide. And people often start and stop the conversation here around do not resuscitate, because that is a decision. It is consent or not to that treatment. And I stress the importance of putting this into context for people, because if you offer it as a menu item, all people hear is, do you want to live or do you want to die? They need way more information than that. And so if you've done the advanced care planning, you know what the patient's goals of care are, you can that much easier make a recommendation to them about do not resuscitate based on their context. So some of the language that I would use with patients would be, you've given me permission to give you more information about what resuscitation means. What we do know is that people with a progressive, life-limiting illness in their final stages, if their heart were to stop or their lungs were to stop, essentially they die. Resuscitation has about a 4% chance of bringing them back to life. And that is just getting their heartbeat started again and possibly breathing again. It does not mean they leave the ICU. It does not even mean that they leave the hospital. And Joan, after we've talked about all your values, knowing that sitting in your garden is one of the most important things to you, and you can't imagine not engaging with your grandchildren on Sunday, I would not recommend you pursue this treatment. And then we're all on the same page. Because if we're not on the same page and poop hits the fan, right, and you have a patient who's been scared into making a DNR order, do not resuscitate or allow natural death, broken bones don't seem so bad when nobody understands why they've made the decision to sign the DNR in the first place. And that is how decisions are reversed. So you have to put it into context for people. Another decision that people have to make is where they want to die. And this is probably where some of the biggest homework for some of you anyways is going to come in. As I said before, our medical education training does not do a very good job of allowing us to see and experience how people live and die in their community. So you may have some questions about this, and you will need to ask the people in the know about what it looks like to die at home. Home care is often a part of it, and just because a family qualifies for a certain number of hours or services doesn't mean they're going to get it. The last thing you want to hear is, I wish somebody told me it was going to be this hard. And then planning for death. Just some other little tidbits. Always have a plan B. Most people want to die at home, but there's a huge administrative burden for getting into hospice and long-term care and other facilities. So if you're in a crisis, you want to have that as your insurance policy. You want to educate the family around normal processes of death and dying. They will be more tired. They will sleep more. They will not want to eat anymore. In fact, if they do eat, their body forgets what to do with it, and it can actually cause more symptoms and problems down the road. Anticipate lost oral access. People will become so weak that they can't swallow their medications anymore. And if there are medications that are keeping them comfortable or that are crucial for preventing something like a seizure, for example, you're going to need to make sure that medications that can go under the skin are in the home for when that happens. People need to know who to call when death occurs. Most people think this is 911, and it's not. In most, if not all, communities. I might be wrong, and you might correct me on that. But knowing who to call, and then asking about funeral arrangements. Often this is something that can be delegated to a family member that is not as directly involved of the care of the patient. And so, if we do this work that I've described in a very high level, right? You could take courses for hours, for weekends on how to deliver a palliative approach. If you do it upstream, we in family medicine have the luxury of sprinkling this in over time. And there are variables like the relationship we have with the patient, the acuity, whether we even have a team to support us. Sometimes it's all on us, sometimes we can spread out the workload. But what I urge you to do for sprinkling it in is, at the end of every current appointment, make sure that there is a follow-up appointment. That is how I have kept track of these patients and not lost them to the chaos of not just the hospital system, but the multiple systems that we end up getting dragged into as we approach end of life. And some practice pearls. So, roster. You need a way to keep track of these patients, again, so you don't lose them. On your EMR, especially if you have a shared practice, it's good to identify these patients in some way, especially for on-call, so people understand what they're getting into and the level of support that somebody receiving palliative care might need. Identify the team on your EMR, and those can be the care coordinators, a primary nurse going into the home, a specialist that's still involved, and of course the power of attorney. Contact, how to get in touch with you and when to do it. In our community, nurses all the time who are going into the home are waiting the hour to wait to talk to the doc because they're going through the same system that all the other patients are to make their appointments, and they don't have time to stick around and do that. So you'll have to troubleshoot quicker ways of getting in touch with you. Scheduling and home visits, I do home visits. I would, of course, encourage all of us to do home visits. I have put a chunk of time in my schedule every week that I dedicate to this, and there is no unmet need for that time and space. You can always fill it. For billing, I didn't go into billing much, but there are various codes. I'm familiar with the ones in Ontario, things that are specific to palliative care, and then there are bonuses for that, and there are travel premiums. So there's a good chance that those exist in your communities too. It's a way of, paying you back for the time and effort that this care takes. And then resources, so knowing what's available to your patients in their community. Home care, referrals, making sure that you have quick access to the referral forms that you use often. If there's private coverage in your community and how to access that. Pharmacies, ones that give subcutaneous medications, ones that are open 24/7. How to get oxygen quickly. And then documents. We talked about the DNR already, but things like power of attorney, which you do not need a lawyer for. There are great toolkits online that just really require witnesses. And then troubleshooting. Everybody needs a phone a friend. I need a phone a friend. I'm lucky to have many, but you will need one too. They can often be found by just calling inpatient teams, outreach teams in the community, hospices, online e-consults, MAID teams, and then there are various services, again, depending on where you live, that can help with certain interventions like pain blocks and things like that. So if you're having trouble getting on top of a symptom. And then grief and bereavement. It is also well suited in family medicine. There are different types of grief. There's the anticipation of what you're going to lose on your way towards death, like a job or your identity. There's acute grief in the time of loss, and then there's delayed grief. And I always worried about delayed grief, especially in those caregivers who eat, live, and breathe caregiving. And then there's a massive void in their life. Often it's a spouse in my family practice, and I call this out early because they are at risk for complicated grief, and I know that I am going to have to wrap more resources around them accordingly. Things you can do are help with normalization, acceptance, expression, support, and staying healthy. I very much encourage grief groups in the community. There's an unmet need for younger people in my community, and there might be in yours too, but there is something about the validation that comes from other people going through grief. Society is not a friendly place for people who are grieving. So we're coming to the end, and it's taken me about 6 years to get to this point, and I have learned so much. I have so much more to learn. One thing I know for sure is that I am a better palliative care physician because I am a family doctor, and I am really proud of that. The struggle for me, however, and again, it goes back to the ego stroking, is recognizing that although the healthcare that we provide in family medicine is absolutely essential, it's really a small portion of the living well to the end equation. And as communities, we need to do better around death literacy, caring for people and assisting them to live comfortably in their homes, and developing the capacity of others to build supportive networks in their community. To learn more about this, I recommend you look up Compassionate Communities. And these are some resources that I put together. Again, they're generic. I focused on national and free resources. And these will be posted. They're not posted already. You probably recognize that. But the good news is there's so many out there. Things you can look up for free online, but also courses that you can take, conferences, workshops. You even just look at Family Medicine Forum. There are always themes around palliative care. I want to end the session today going back to the quintuple aim. And I want to talk just about two patient stories. One was a young woman that I had with breast cancer, and she had a fierce advocate of a husband who did everything for her. And they had a young 4-year-old daughter. And unfortunately, the cancer had gone to her brain, and because of that, she had lost or was losing the function of her hands. Also, because cancer was in the brain, she was incredibly thirsty. And so the husband was up all hours of the night trying to get her water and not spill it and navigate the bottle. And they were relatively new to the country, so they weren't immersed in hockey culture yet. And this is the first thing that popped into my head. So I ran to a store, I got a $3 bottle, I brought it over, and it was like I had given them a pot of gold. I talked to them the next day, and it was a game changer for this family. So the key message in this story that I want you guys to take away from this is the simple things in this type of care can make the biggest difference. My second story, what you would not know about this woman is how riddled she is with cancer. I've used this slide in both of my stories with permission. She was her own fierce advocate, one of the most stubborn people I've ever met in my life. Surprise, she was in healthcare. And she decided, which was in retrospect, about 3 weeks before she died, that she was going to go back home to Colombia. And this is her farm that she wanted to get back to. And she has already had fractures in her bones, she has cancer in her brain, so many complications, and I'm just thinking about this woman traveling to Toronto, getting on a plane, being in the plane, pressure changes, landing, getting to the farm. One unique aspect is that she still had health care in Colombia, which is kind of a game changer for many of our other patients that really want to go home. It's a very common desire. But that's what we did. We sat down and we played out every possible scenario that we could think of. And we planned. We came up with action plans, and I pre-medicated the heck out of her before she got on that plane. And so the message I want to give to you again about this care before we leave today is, what I love about this work is sometimes there's freedom in it, in that we can throw the guidelines out the window and just have some fun and creativity trying to really help people find meaning in their life again. And that brings me to the end of my talk. Thank you for joining me today. Happy to take any questions if you have any.
Hello, Dr. Gallagher.
Hello, Dr. Van Wilruben. She's not planted, I swear.
Just because this was a very recent conversation in my own practice, but how do you combat the language that families and patients bring into your office around defeat? I am a fighter. I'm going to fight this. If I don't want to stop, that means giving up. What's your approach to responding to that type of language?
Yeah, it's a great question. I think the first step, and that's something you're already doing, is recognizing it, right? When you hear those words trigger me, right? Because it automatically means that time and space is likely not available for that patient to grieve. And that is a part of healing. So we can negotiate together ways of hoping for the best, whether we want to call it, fighting that battle or fighting the good fight, but also making sure that we carve out time to recognize that this situation just really sucks, right? It's important to be able to acknowledge that, and for everybody, because patients feel ignored when that is the only message that's being given to them by family. They don't feel heard, and they protect their family and don't want to bring them down. And so we talk about how hope changes over time, hope for the best, plan for the rest. Talked about that a little bit already, but even though we might hope initially for a cure, it might then turn to hoping for a longer life. It may then turn to hoping for more comfort, or that last trip, or being able to die at home, or one last visit with a friend. So those are the strategies and approaches that I use, but it is so important to call it out. Thanks. Hi.
Hi, Dr. Gallagher. My name is Kathy Paddock. I work for Health Canada. I have a quick question and then a shameless plug for something free, so I think we could do that.
Awesome.
So my question, it's interesting to hear you talk about the illness trajectory, but also the patient experience trajectory, and that's not something, I'm not a physician, so I was less familiar with. So interested in hearing more when you talked about, okay, at the 3-month mark, that's when the freak out will happen. At 6 months, that's when you'll question everything. Are there places where I can look for more information about that? Because I think that's, from a patient perspective, really important to understand, as well as how the illness tends to go. So that was my question.
Yeah, so you're asking about specific prognostic information?
More so about the patient experience of receiving that kind of news. Like you said, at 3 months, typically patients will freak out. At 6 months, typically patients will question everything, like that kind of behavioral stuff. I haven't seen that too much, so just piqued my interest.
Yeah, and I would have to say that, like much of this presentation, a lot of that was anecdotal. Okay. So I can't refer you to resources about that, but in my experience, it's what I often see.
That's fair enough.
Yeah.
And then the shameless plug is we have a very simple handout that Dr. Sammy Winemaker and Dr. Sien Xiao helped us with. That essentially is the information in your presentation, but just boiled down to the 3 questions that you want to ask about the illness, and you've explained it beautifully. So please come to booth 1006 and check that out, and it's free, and please take those home.
Awesome, thank you for that. All good? All right, thank you.